So adipose tissue, we've known for a long time of the benefit of using fat tissue in surgery. In fact, it was the plastic surgeons that first took note of fat when they grafted for certain areas of damage and defect with cosmetic surgery. And they filled that with a fat graft. They noticed the skin had a rejuvenated appearance. It seemed to do something positive for the skin. And from that, over the last 20 years, we've learned a lot about the cells within the fat that are very important for healing, regeneration, and for improving problems such as osteoarthritis. Within the fat are stem cells. They're called pericytes, and those pericytes are pre-stem cells, and they become active, and they become active stem cells once they undergo a certain type of reaction, which is caused by, for instance, taking them from the body and injecting them. That will activate the pericytes. And you've got two different types of stem cells. You've got, in terms of treatment, you've got pure stem cell treatment, where we take those fat cells, those pericytes, and we expand those in a laboratory over a 2 or 3 week period, and then we can inject those intravenously or into the joints. Or we can use what's called minimally invasive stem cells, which is using fat, filtering it, fragmenting it, washing it, and it's that filtered and fragmented fat that has a very, very good effect in terms of what we do within orthopedics in terms of managing pain, swelling, and trauma from surgery or from injury, or indeed from the aging process and osteoarthritis. Fat and stem cells from fat can be used for anyone. But the advantage of fat in the adult population is that in individuals over the age of, say, 40, 50, to getting a little bit older, we don't see the activity falling off in terms of the stem cells. It actually is maintained. In someone who's 80 or someone who's 90, if they break their leg, they still heal, and indeed their fat is still active. So the system that we use for microfragmented fat is called Lipogems, and there's many different types out there, but we like this system because it has some good scientific evidence. In fact, there are now over 100 peer-reviewed articles supporting the use of microfragmented fat with the Lipogem system, and over 30 of those are in our field of orthopedics. To be specific about how we would use it, there are two main ways in which we use this. The main way is to manage the pain of osteoarthritis, and the most common joint that we inject is the knee. So we've treated over 2,000 people at the Regenerative Clinic with this treatment, and 80% of them have had an injection to their knee, and it seems to work extremely well. And that's based on our results. We've collected a lot of data, and also the results from Hospital for Special Surgery in New York. It's used at Harvard, it's used at Duke University, it's used at multiple clinics around Europe, the high-profile centers of excellence. Many of them in Europe are now using this treatment. In fact, there's a lovely study just about to come out of Antwerp from Peter Verdonk, showing significant pain reduction at 2 years in osteoarthritic knees. Most people quote about 80% success in the patients that have this, and in terms of the patients that we're treating, the majority have got at least patches of bare bones, so they're what we call grade 4 arthritics. And a lot of our critics would say, how does that work? How can you inject someone with bone-on-bone arthritis with an injection of fat and make their knee feel more comfortable? And what I say to that is, first of all, there's good evidence for it, so we're very glad to have that. But in terms of the basic explanation is, there is no great correlation between the amount of wear and tear and the amount of pain. So you can have a very small area of damage in your knee, and you can't walk up and down the stairs, you can't sleep, you can't function. You could have a completely global destroyed joint, and you still play tennis and you run around and you've got no pain. So just because you've got arthritis doesn't mean that you're going to have pain. And what the injection does is it is an anti-inflammatory injection, and hundreds of proteins are released by the fat and the pericyte working in concert with each other, like a mobile pharmacy, to use Arnold Kaplan's, Professor Kaplan's explanation, and the fat and the pericytes interact. It's that interaction that's very important, and release lots and lots of key proteins that reduce inflammation and reduce pain, and that can persist for a very long time. So we have a lot of patients now at 3 years who are still reporting good benefit from their injection. Fortunately, it's a very safe procedure. There is a risk of bruising because we normally take the fat from the abdomen, from the tummy area. You might get some bruising there, but if you do have that problem, which is rare, that normally settles within a day or two. There is a risk from the anesthetic, which is a sedation as opposed to a general anesthetic, but still carries slight risk. But of course, we've made that very safe. There is a risk of introducing infection into any joint that we inject, but to our knowledge, no one has had a deep infection from the use of Lipogems in the knee globally, and we haven't seen that in our clinic. We've seen some adverse reactions, so we've seen people saying, wow, my knee feels worse. Fortunately, that's really uncommon, and if it does occur, it normally settles very quickly. The biggest risk is it doesn't do you any good, and you feel it's been a waste of your time, and you're a so-called non-responder. And that, of course, is very disappointing for the patient and for us, but there is a failure rate of around about 20%. But if we put that into context, there's also a failure rate of 20% with a total knee replacement. And if that goes wrong, the consequences are much more significant. So in terms of who is ideal for this, it's somebody who has got arthritis. We know it works best in the knee, but we also often treat the hip, the shoulder, the thumb, but we know it works particularly well in the knee. The level of their arthritis can be up to grade 4, so it can be complete destruction. It can be in more than one compartment. In other words, it can be a global disease. We would rather get to people earlier, so we'd rather see people in the earlier phases of arthritis, but often people don't present until it's gone that far and the camel, his back is finally broken with that piece of straw, and they present late with grade 4 arthritis. In terms of age, there's no age cutoff. We offer this up to very elderly people and young people. I would say that it's something that on an escalator of treatment, before you get to say, I want to have that surgical procedure, there are many different things that you can try. Unloading bracing for the knee, for instance, which is the joint I'm most interested in, an unloading brace. Of course, you can try steroid. Of course, you can try hyaluronic acid. You can try PRP. You can try advanced end-stride PRP. You can try bone marrow aspirate, or you could try microfragmented fat. These are non-surgical options, plus, of course, physiotherapy and lifestyle modification that anyone can try before they go for surgery. Then I say to them, in terms of the surgery, if you want, we have knee distraction, which is often not discussed with patients who are at the end of the road with their knee, or a partial knee replacement, or an osteotomy, which is something, of course, that we're actually very well known for. And then, of course, there's total knee replacement. So anyone with arthritis has all of those options. And the question is, at what point do you want to have each intervention? And if you would like to start with something less invasive, microfragmented fat is often a very good option.